Absolutely, Dr. Ramon. Here's a set of USMLE-style questions focused on severe glomerular basement membrane (GBM) damage, causing simultaneous hematuria and proteinuria, often seen in mixed nephritic nephrotic syndromes, especially in conditions like diffuse proliferative glomerulonephritis or membranoproliferative glomerulonephritis. Question 1. Mixed renal syndrome. A 23-year-old woman with systemic lupus erythematosus presents with facial puffiness and dark urine. Labs show hematuria, proteinuria, 4.0 grams per day, RBC casts, decreased C3 and C4. Which of the following best describes the pathophysiology? A. Podocyte effacement only. B. Tubular reabsorption defect. C. GBM rupture with podocyte damage. D. Mesangial IgA deposition. Answer C. GBM rupture with podocyte damage. Explanation: severe GBM damage leads to both RBC leakage, hematuria, and impaired charge barrier proteinuria, features of a combined nephritic nephrotic syndrome. Question 2. Urinalysis pattern. Which combination of findings is most consistent with severe GBM damage? A. RBC casts and mild proteinuria. B. WBC casts and low complement. C. Hematuria and proteinuria, 3.5 grams per day. D. Bacteria and leukocyte esterase. Answer: C. Hematuria and proteinuria, 3.5 grams per day. Explanation: simultaneous gross proteinuria and hematuria suggest combined nephritic nephrotic pattern, often due to severe immune-mediated GBM injury. Question 3. Lupus nephritis presentation. A patient with known lupus develops hypertension, edema, and decreased GFR. Urine microscopy shows dysmorphic RBCs and heavy proteinuria. What renal pathology is most likely? A. Diffuse proliferative glomerulonephritis. B. Minimal change disease. C. Amyloidosis. D. Diabetic nephropathy. Answer A. Diffuse proliferative glomerulonephritis. Explanation: DPLGN is the most common and severe renal manifestation of lupus, often showing hematuria plus nephrotic range proteinuria. Question 4. Mechanism of hematuria, proteinuria. Severe immune complex deposition across the GBM causes both hematuria and proteinuria due to A. Mesangial cell hypertrophy. B. Disruption of tubular reabsorption. C. Damage to endothelial, GBM, and podocyte layers. D. Urethral inflammation. C. Damage to endothelial, GBM, and podocyte layers. Explanation: injury to all three layers of the glomerular filtration barrier allows both RBCs and proteins to leak into the urine. Question 5. Key microscopic clue. A biopsy from a patient with hematuria plus nephrotic range proteinuria shows wire loop lesions on light microscopy and granular deposits on immunofluorescence. What is the underlying disease? A. Focal segmental glomerulosclerosis. B. Post-streptococcal GN. C. Lupus nephritis, class 4. D. Membranous nephropathy. Answer: lupus nephritis. Explanation: wire loop lesions equals subendothelial immune complex deposition in class 4 lupus nephritis, often presenting with nephritic nephrotic syndrome. Combined GBM damage feature finding severe GBM injury, RBCs, hematuria, proteins. Urine microscopy, dysmorphic RBCs, RBC casts, proteinuria. Associated diseases: DPLGN, MPGN, RPGN. Labs: GFR, CR, C3, C4. Would you like me to